My name is Brian Evans. I'm an orthopedic surgeon in the Department of Orthopedic Surgery at Georgetown. I'm the director of the Joint Reconstruction Center at Georgetown. We provide total hip and total knee replacement for patients who have arthritic conditions that affect primarily the hip and the knee joint. We also have surgeons who can take care of any joint in the body from a reconstructive perspective. We have a lot of advantages at the Joint Center here at Georgetown. The facility itself has soup to nuts in terms of sophisticated, high-level physicians to take care of patients with a wide variety of medical problems. In addition, when you get to the specific orthopedic conditions, we can handle anything from a very simple, straightforward, first-time total hip or total knee replacement to the multiply operated on, failed, infected, complex reconstruction. And so we can handle patients completely throughout that range of care with a high level of competency and with a great deal of care and skill. Well, there's no question today people are much more active, much more mobile, much further along in their lives than they ever used to be. If I look back in my childhood, if I had a grandfather who was in their 70s, they really were someone who was not very active or very mobile. Now these patients are traveling the world. They're going and doing all different types of sporting activities. They're climbing mountains, doing stairs and hills in Israel. I mean, they really are a much more active population than they ever used to be. The most rewarding aspect of what I do is taking folks who are very impaired and restoring them to a very mobile, functional, active life. It's very difficult to determine exactly when the surgery should be done. From a technical, surgical, anatomic perspective, whether the surgery is done immediately or it's done in a number of years, it really makes very little difference. What really makes the determination is the impact the arthritis and the pain that arthritis has for the patient on a day-to-day basis, how that affects their life. And it's almost as though they have an epiphany. They'll wake up one day and just say, you know, I am just really tired of limping. I'm really tired of taking this medication. I'm really tired of having a very difficult time going up and down the stairs or getting out of the car. And then they're really ready for surgery. The majority of patients are in the hospital for about 2 days. It seems like a very brief period of time, but our goal after joint replacement is to get patients active, functional, and mobile. We get patients fully weight-bearing as soon as we can after the surgery. Frequently they're on a walker only for a couple of days and then move to a cane, and then getting off of the cane after just a few weeks. We try and get the majority of patients discharged to home, and we have home services that can come out and actually interact with the family, interact with the patient to make sure it's a safe, reasonable environment. For patients who aren't quite as mobile, who have a difficult time getting in and out of bed or in and out of a bathroom, we may have them go to rehabilitation for a period of time. Usually that's less than a week or just around a week. But currently the majority of patients are able to go home, get back into their own bed, into their own bathroom, into their own life very quickly. With the current technology, the replacements are really marvelous devices. Many of them should last 20 years or more. Some of the technology may even last further. One of the challenges we have is we don't have clinical results that extend out that far because as the technology evolves, we can't really, we're more anticipating based upon past results. But the current technology should last 20 years or more. That's a question we get asked frequently, and it's really not a matter of chronological age. It's a matter of, to some extent, what we call physiologic age. I've had patients in their mid-90s who are very active, functional, live independently. I had one woman who was, again, in her mid-90s. She couldn't get back and forth to church. She was in a wheelchair, and she had 2 hips that were very arthritic. There were a number of doctors who told her that she was too old for the surgery. And the problem is, even though she was having pain and she had limitations in mobility, the bigger factor was she was having pain on a day-to-day basis. Just moving in and out of the wheelchair, trying to sleep at night, she was in severe pain. So we did go ahead, bring her in. We got a complete medical evaluation, but we provided her with 2 hip replacements. And she came back in overjoyed. She was able to walk back and forth to church. She can go to the grocery store, and she's quite functional. The oldest patient I've done primary joint replacement on was 97, and she lived to well over 100 and did very nicely. So there isn't a strict chronologic age. It's really a matter of if a patient is healthy, if they're in good physiologic condition. It's very reasonable to go ahead and provide them a joint replacement and get them back active and functional. Patients who have joint replacement can really be quite active and functional. Things that involve running are probably not the most encouraged, and running for sport is probably not the most encouraged. But they can hike, you can climb, you can water ski, you can snow ski. You can use all the varieties of equipment in the gym in terms of ellipticals, stationary bikes, Nordic tracks. They can do weightlifting. You can really be quite active and functional after joint replacement. Running over the long term probably would shorten the longevity of the device, but even intermittently, if patients play tennis just a few times a week, they can do that quite safely, and it won't really impair the longevity of their implant. We try and get patients up on their feet and walking as rapidly as possible after the surgery. And while you can immediately weight bear, certainly it's sore. You've just had surgery, the muscles are tender, and over time, as you get walking initially or with a walker or crutches for about a week, then move on to a cane. By about 2 or 3 weeks, you're getting rid of that. It'll still be somewhat sore, but usually by about 4, 5, 6 weeks, you should be walking much more normally. By 2 to 3 months, it's really starting to drift into the background, and by 4 to 6 months, it really is just part of you, and it just feels like a natural part of your body. The devices themselves, at least in the last 15 to 20 years, have not changed dramatically. The materials are relatively similar to what we've had. What you find across all manufacturers is the devices actually look fairly similar. And the reason for that is there are certain shapes and certain sizes of implants that just work. They are very effective and very functional for patients. What has changed is the articulations, where the parts come together and where they actually rub or move. The materials that we use in those areas have undergone dramatic changes in the last decade, and that alone has resulted in a significant increase in how long we can expect these to work. The plastic is much improved, the surfaces that they articulate against are much smoother, the wear rates are dramatically reduced. The way we even sterilize the materials has changed quite a bit. The way that we used to sterilize the device actually created a process of oxidation, where the material itself would start to break down and it would wear at a much higher rate. By changing the way we sterilize the materials, they don't oxidize that way, and that has resulted in a significant improvement in how long the device will last. There is pain with joint replacement. We are working on the bones, we are working in and around muscles. There are a variety of different approaches, but whether you stretch the muscle or cut the muscle, it still tends to swell and can be sore. One of the greatest things we've introduced since about 2008 has been a multimodality pain protocol. And this has been highly effective at relieving pain and getting patients much more active, much more functional earlier. If you can control the pain, the patient can walk faster, they can get up better, and they can move much more readily after the surgery. The pain protocol is a multimodality approach to taking care of pain. It begins even before the surgery. We give patients a group of medicines to help combat pain before we even have performed the surgery. We use injectables right around the site of the surgery. We have a device that will administer local anesthetic into the area of the operation to help alleviate pain in the first couple of days. And then there are a series of medicines, both anti-inflammatory medicines as well as pain-relieving medicines that we administer after the surgery. And they are gradually changed over the course of the hospitalization and over the course of the recovery to keep the pain controlled and yet keep the patient awake, active, and functional. The patient who's the appropriate candidate for surgery is tired of dealing and living with the pain that they're having currently. If they're able to live and tolerate the pain that they're having on a day-to-day basis, they're not really quite ready for the surgery. What I recommend for patients is, if you, in your mind, as you envision your life and your day-to-day activities, if you could go on for 2 years with your pain as it is in the current state, you shouldn't have the surgery. You're not quite ready, you're still too functional. Keep doing what you're doing, keep getting along, and over time, though, what tends to happen is the pain tends to gradually get worse. And it's at some point they will cross over a threshold. And if the patient thinks they don't really want to live with the pain as they're currently experiencing it for 3 to 6 months, then they're really ready to have the surgery. The implants, the devices that we use for total hip and total knee replacement are very different. For total hip replacement, the majority of those devices are non-cemented. In other words, there's a coating on the device that the bone will actually bond directly to. And so we implant it very firmly in the bone, and the bone actually grows and incorporates the implant directly into the skeleton. The articulation, the parts that actually come together, are really sort of the workhorse of the device. Those currently are either a metal or ceramic femoral head and a cross-linked plastic liner. And it's a very, very durable device. In the knee, the nature of the bone around the knee, it's not as amenable to non-cemented fixation. So the majority of knees are actually cemented onto the end of the bone. The bone cement is a plastic that actually will adhere the device directly onto the skeleton. And so it's immediately fixed rigidly onto the bones. Those devices are made of cobalt chrome, and they have a plastic bushing that fits in between. Well, joint replacement, while we do it quite commonly, it is a big operation, and it does have certain complications that can occur. The most frequent complication is blood clots in the veins of the legs, and one of the best ways to prevent that is to be up, active, and mobile after the surgery. We also give patients a blood thinning medication after the surgery. That helps to reduce the rate of blood clots, but probably the single most important factor is activity. Patients also may need a transfusion after the surgery. We don't collect blood from the patients anymore. We used to do that. What we found is the patients who would donate blood, because you just donated, you're anemic, and as a result you would then need the transfusion much more commonly. With the current techniques, we really don't lose as much blood, and so the likelihood of needing transfusion is really very low, and so we don't have patients donate their own blood. The most feared complication is infection. We do many, many things around the time of surgery to minimize the risk of infection, but it is something that unfortunately can occur. The joints can also dislocate, where the two parts of the joint that we put in can separate, and so you may need to be careful with how you position your body after the surgery. The restrictions in activity or positioning only carry on for about 6 weeks, and then after that you can basically use your hip as you would feel comfortable and natural with it. And the physical therapists are very diligent about going over that with you, and the instructions are quite simple and very easy to maintain. The majority of patients coming for joint replacement do best with epidural or spinal anesthesia. While that is somewhat daunting for many patients, it's not as though you're awake during the surgery. You're actually sedated and you really have no awareness of being in the operating room or having undergone surgery. But because you're not completely asleep as you would be with a general anesthetic, when you wake up you feel much better, you're much more awake and alert, you're much better able to participate with physical therapy, and also just to interact with your family and interact with the other healthcare professionals that will be coming in to take care of you. The majority of joints in the United States that are replaced are the hip and the knee. Other joints that we have viable replacements for are the ankle, the elbow, the wrist, the shoulder. Any of those can be replaced, and we have specialists at Georgetown who can do all of those.